Welcome to Ortho Insider, the Canadian Orthopedic Association's podcast that goes behind the scenes and looks at the humanitarian side of orthopedics. And what better person to look into the humanitarian side of orthopedics than Dr. Supriya Singh? I'm very excited to have you on this podcast because I've actually had the opportunity to get to know you when we were both residents and fellows at Western and subsequently when you're a spine fellow at the University of British Columbia. Currently, Dr. Singh is an orthopedic spine surgeon in London, Ontario at Western University with an interest in global health. She was awarded the Canadian Orthopedic Association's Emerging Leader Award, and she's currently the president of COAGS, which stands for
the COA Global Surgery Committee.
So you are very, very active in humanitarian initiatives, including with Broken Earth, and you are an incredible educator. I know this from firsthand, and you've won several teaching awards in residency, in fellowship, but I'm sure soon to be, if not already, as an attending. So welcome, and thank you for being here.
Thank you very much for that introduction.
Supriya, tell me a little bit about your path to not just orthopedics, but to global health.
Sure. I guess my path to medicine started early. I was a first generation Canadian, so my family's all from India. I was very privileged to be born in Canada. Education was something my mom said, that is what changes the world. So very early on in my life, I realized the stark difference of me being brought up in Canada versus another child in another world being brought up in India. So my mom took us back after my father had passed away. My mom brought us back to India, and we got a very real sort of awakening of what the world is like and the disparity in healthcare in the world and how people live, and the difference between me as a well-dressed kid versus someone in the slums who has no food, no house. Like, how is that fair? So that sort of inequity was something my mom really highlighted to us as children and said the way out of that is education. So you educate yourself, you study hard, and that's what's going to get you to be in a better position in your life. And so that was driven into me, and with that sort of took that running and worked hard in elementary school and high school when most people are doing cool things. I was studying, but I really took my mom's words to heart, and that's really what led me into medicine. And I was very grateful to have great mentors in orthopedic surgery and spine surgery, and that kind of guided my path to become sort of a spine surgeon that I am today. In terms of global health, along the way, again, that inequity in care, I always knew I wanted to do something to give back. And in medicine, I found very few areas where I could make tangible differences. There's a lot of chronic disease, but orthopedics is actually a very selfish move on my part because it's instant gratification when you can fix something that's broken. You understand the problem, you know how you can fix it. I felt that really helped me to understand medicine and make a tangible difference. And I really knew that with orthopedics, I wanted to do global work. I really thought, to me, that meant either pediatric or adult trauma. I did not understand that could be spine surgery, but I had a great mentor that led me to the path of spine surgery, and also that we could do this in low middle income country. That really got me involved in this path.
Did you ever feel, coming from immigrant parents and being first generation Canadian, a pressure to make the most of your parents' sacrifice?
Absolutely.
I ask because I have a bit of the same experience in the sense that I'm also first generation Canadian and from Asian parents, and there's always this very immense pressure to succeed academically.
Absolutely. And I'd have to say credit to my mom for never making me feel that I wasn't good enough if I didn't get a grade, so I didn't have that pressure. A lot of that pressure was internal. It was internally driven because I saw my mom sacrifice for me every day. She was a single parent, raising 2 young children by herself, and she sacrificed her entire life for us. So for me, it was like almost my duty that I had to make it to get scholarships, to get into university, to get into medical school. I felt that was on me. And so that's where that internal drive came from. But I do think it's that sacrifice that we see every day that helped motivate me to kind of pick that path.
It's interesting because when you say that, you hear those stories and some people thrive under that internal pressure and some people burn out. So can you talk a little bit about some internal resilience that you may have, growing up or seeing, as you mentioned, your mom being a single mom? Tell me a little bit about that.
Yeah, that's a great word, like resiliency. And I don't often see myself as that, but I I kind of identify as like one of those weeds, you can never get rid of them. They will grow even in the most starved conditions. Like I do tend to want to prove myself always and stand tall and say, I can do this even when other people may not believe in me, or when I might not be in the environment that's set up for success, but I want to show everyone that I can. So, and I think that came from seeing my mom prove so much that she could. And so I said, I can do this as well. So I had a very strong female role model. And then, I guess that's really where that comes from. And I don't know, everyone has a different story, a different path, but I took that to mean like, I just have to keep pushing. And that's really what I've done. And I think that somewhere along the line, a lot of those tendencies has led to my success, but also I have to reflect on that a little bit, because, you lose yourself sometimes too in that kind of constant grind, and then you stop and you say, well, how do I take care of myself? How do I not burn out? And I'm still learning that, because I haven't learned those skill sets along my way, but I've learned other skill sets.
Yes, that's really interesting in and of itself, because you talk about wanting to prove yourself and not losing yourself, especially in a busy orthopedic residency. As a female orthopedic surgeon, tell me about some of the extra barriers that you may have encountered, or some of these biases that you may have encountered throughout your career, and how did you overcome those?
Absolutely. I think, we do talk a lot about diversity in orthopedics, gender being one of them. I think orthopedics has made a lot of ground, and I'm certainly very privileged to have gone through orthopedics at a time where I don't think that I was judged for my gender. But certainly there are some subtle things that happen on a day-to-day basis where male and female surgeons, orthopedic surgeons, doctors get treated differently, like the assumption that I must be a physio or nurse or a secretary in the hospital, that even as a practicing surgeon, I have to wear a white coat for someone to, say, oh, she's the surgeon. That's always there. That's kind of ingrained in the culture, some of those differences. And I think as a group, we're really working towards changing that. I dealt with that a lot as a resident. And I think the best way that I've learned to deal with it is talking to people, finding allies, and realizing that together we can change the culture. And so I think that's the future for orthopedics. And you can even see a huge difference, I think, from when I started my residency training to now as a staff consultant, looking and seeing the female residents that we have in our program.
Amazing. There's a great story that you told in another interview where, as a fourth-year medical student, you're in Tanzania and you're trying to manage a patient who has a terrible motorcycle accident, and you had one Tylenol, one antibiotic, and no implants. And while you were very distraught by this, you reflected and saw that around you there was a lot of hope, a lot of community, a lot of resilience. Tell me about how that has affected your career, and compare and contrast some of those things that you see from a country that has so little yet so much hope, and a country like Canada or North America that has so much yet has so much mental health problems.
Yeah, no, thank you so much for bringing that up, because I think that's such an interesting point. I've talked about it with our current fellow who's from Kenya as well. There's many differences, and there's certainly disparity across the world that we see, and in healthcare especially. But when it comes to community and when it comes to family or friendship, it's very different in North America than it is in some of these countries. And I've always struggled to find home. Like I don't belong in India because I was born in Canada. I sometimes feel like I may not belong in Canada as an immigrant. So I struggled to find, like, where is home? Where do I fit in? Like, who am I? And the place where I really felt the most at home was in Tanzania, because I stepped off the airplane, I took a deep, breath, and I just felt like this is my home. And it was really because of the community. So the people that I met there, they're family. Like, even though they have no blood relation, they take care of each other. Like, the village comes together to take care of people. Like, I stayed with some street children, and they all had one set of clothes, but they share them so that each day they wear different clothes, and they, to anyone else who would look at them, they wouldn't know that they were a street kid. If one of those children got the opportunity to educate, he would come back and teach the other ones. Like, it was this unity and community that I didn't have in Canada. And I thought, wow, this is incredible. So that even though, yes, it's horrible that I can't help this individual who's in trauma, but to know that like an entire church or community would like mobilize to try to fund this person's care. Like we don't see that here, or at least I don't in my community. So, even sometimes neighbors are strangers in our community versus there, like, if someone was sick, everyone would be bringing in food coming from wherever. So that was something that I really appreciated and made me feel at home.
Why do you think we don't have that here?
I don't know. I think that we're a very driven society and everyone has a lot of internal motivation and we're a free society and we can live independently. So one of the things that I find, like, at least in my experience in Tanzania, was you have to rely on people to succeed. You can't individually be successful because everyone was limited in their ways. Whereas in Canada, I could be individually successful. Like I actually don't need to be married. Like I'm financially independent. I don't need to have my neighbor as my friend. I can buy my own food. I can get my own milk. Like I don't need to rely on people as much. So because I can be independent, then maybe that's what's driven some of our more independent society. I don't know the answer, but that's some of my thoughts is like, because I don't need to and I can do it independently, maybe that's what's divided us a little bit.
So now you're an emerging leader within the Canadian Orthopedic Association. And you roll your eyes, but it's true. I mean, just look at your body of work speaks for itself. And you are one of those leaders that people are just drawn to you for your leadership style. Taking all those lessons that you learned in Tanzania as part of your global health initiatives, as all those lessons about resiliency, community, how do you as a leader, how are you going to pass that on? And how are you going to use that in your career to help your career as well as the next generation?
I struggle to listen and accept what you're saying because I really don't see myself as a leader. Like I'm just starting out in my career. So it's interesting to hear that you actually would say that about me. I think that may be why people can relate to me or feel that, okay, we can look up to someone like that because I don't feel that I'm any different than anyone else. I really feel that I've been quite privileged and my leadership or the position of the chair position in global surgery was really just because, other people couldn't do that job and I was kind of there to step up with some experience. So I feel that a lot of it's just timing, luck, opportunity, hard work, not necessarily that I don't feel that I'm a natural born leader of any sort. I think that, if people do look up to me as a leader for any reason, I would just say to them that we're all one, we're all the same, and you just do what gives you passion, work hard at it, and everything else comes. Because that's really why I'm sitting here. I don't know why you asked me, but I think that's why I'm sitting here.
Now as the president of COAGS, this is a big passion of yours. What is your vision for COAGS and global health in general?
Yeah, so COAGS is a group of very successful individual surgeons who've done incredible global health work. So I feel as an imposter to be the chair of this group because these people have done more for global health than I have ever done. But what we're trying to do as a committee is really unify the efforts because oftentimes in global health we're working in silos and we're really reproducing our efforts at each site across Canada. So a group like USTOP from UBC or Team Broken Earth, we can unify those groups and create that same model. So for me to start Team Broken Earth in London was so easy because, I reached out to Dr. Fury and Dr. White and they helped me set that up in my program without having me start from zero. I started with an association and a group. So we're trying to help unify people that are interested in global health and give them sort of a leg up as to how to start if you want to get involved. So we want to be that contact point, and we also want to help unify or unite some of the efforts that are being made, but also we're really working on education. So because of the pandemic and the restricted travel, we focused a lot on trying to develop some curriculum. So right now we're working with UBC and MSF to develop a curriculum in South Sudan for orthopedic emergencies, because really they have no orthopedic training. And so we're working on curriculum development, doing Zoom meetings and teachings. We're also working with the Canadian Association of General Surgeons, because there's a lot of rural general surgeons in Canada that have no access to an orthopedic colleague. And so what do they do when someone needs a fasciotomy or an X-fix? A lot of the definitive orthopedic care is transferred to a bigger center, but when they're remote and they're the only one, what do they do? That's not involved in their general surgery training. So we're working with them to try to collaborate and see how we can help the orthopedic curriculum develop for them. We're shifting from the short-term surgical mission work and getting people, to travel to say, how can we refocus to education and even within our own country?
That's a perfect segue to our discussion now about growth orthopedics. And we're going to bring in one of your colleagues, Dr. Parham, Rasoulinejad. Supriya, we're going to change course and talk about some of your global health initiatives. And we brought on Dr. Parham Rasoulinejad, who is the program director at Western University and your mentor when it comes to global health initiatives. Is that fair to say?
Absolutely, absolutely. And mentor in spine surgery and life, really.
Amazing, the perfect person. Tell me a little bit about how the both of you got started in global health initiatives.
Sure. Maybe I'll start. So I started in medical school. I really wanted to do global outreach. But of course, as a medical student, you have fairly limited skill set. So really the opportunity was just to travel and see and explore and understand sort of the imbalance, the inequity that exists within healthcare systems across the world, and then bring that back to try to understand how can I actually make a difference? How can I really help with medicine? And so for me, that took me through surgery, orthopedic surgery, and interestingly, spine surgery. So when I was a junior resident in orthopedic surgery training at Western University, Dr. Rasoulinejad was more of a junior staff. And so, one day in the OR lounge, I was quite frustrated because I was trying to get some global health initiatives started in London with our trauma team or spine or wherever we could see to make work with Team Broken Earth. And he just naturally volunteered and said, I've done this before. Let's get this restarted. No problem. Put my name as the staff. And when he gave me that ticket, it was like the golden ticket to get and facilitate starting some global outreach work in London, at least at Victoria Hospital through Team Broken Earth. So we were able our first year to collaborate together. And he did a lot of the legwork in getting equipment and bring our team together. And so we went to Haiti, and we were supposed to do trauma and spine, with spine being, we weren't really sure where that would lead us, but because of all the equipment we had and the actual need that we found, we ended up going back multiple years just doing spine surgery, which was, an incredible experience. So that's kind of how we got started as like a small, short-term surgical mission work.
Yeah, that's incredible. So, Parham, same thing. How did you get started yourself in global initiatives and humanitarian missions?
So my version of the story might be a bit longer, so feel free to edit it out or put it on fast forward. I'll sound like a chipmunk, but that's fine. Mine probably really started from childhood, actually. I wasn't born in Canada. I was born in Iran. And in fact, I was born in 1980, and that was essentially the start of the Iran-Iraq war, which meant that at that time, the country that I was born in had significant challenges in multiple aspects that certainly don't relate to this conversation. But I specifically remember, even as a child, I was playing around and I hit my head against the corner of a window, got a big gash, was bleeding everywhere, clearly needed some kind of medical attention. And my neighbor ended up driving me and my mom to 4 different hospitals to try to find sutures. We would go to one hospital and they say, yeah, he needs sutures, but we don't have any sutures because it's all going to the war effort, I suppose. Besides that, my family also lived in Ecuador, and my sister there had health challenges. So I'd experienced how difficult it can be to get health care in countries that are underprivileged. And when we finally made it to Canada, I made a point of making a promise to myself or to a greater power, I don't know to whom really, that if I was successful in the medical field, that I would dedicate some of my time towards global health to try to help where I could. Being fortunate enough to be in Canada and be able to do that. And so I was lucky enough to get into medical school. And during medical school, I remembered that commitment that I'd made as a high school student to myself. I went on one global mission at that time to Kenya. It was extremely unsuccessful. I had no utility. The little knowledge that I had was completely useless. And I came to realize that, you can have good intentions, but you can't actually provide healthcare without infrastructure. Like, healthcare is not a doctor going out in the field and handing out, malaria pills for the most part. Like, you need to have infrastructure, you need to have help, you need to have a team, you need to have resources, you need to have funding actually be effective. So that's what that taught me. I ended up finding a mentor while I was in Kenya. Interestingly enough, at a mission hospital that I visited for a couple of days. He was a general surgeon and just a fantastic guy. And I was going to become a general surgeon to role model him. Came back to Canada, got back into the busy, medical school thing, and really liked orthopedics very much for selfish reasons. Like, I like tools, and orthopedics has a lot of tools. And I said, well, you know what? I might as well do something I enjoy doing for whatever the reason be. So it's a lot of confessions. This is going
good.
public. Yeah.
Yeah, exactly. Careful what you say.
Exactly. Gotta be careful here. I went into orthopedics. I tried to, while I was a resident, I tried to think, okay, well, what can I do in orthopedics that has global health influence? And the way my research was going and job opportunities and my interests and gained individuals that I met during residency who were mentors to me, I ended up going to spine. And when I picked spine, I assumed that perhaps I would have to forego this promise that I made to myself when I was in high school, on the account that I didn't think spine surgery would lend itself to global health. So I said, okay, I'm sure I can figure out something to do. Then, did my fellowship, started working. Every 3 months or so, I would have this 30 seconds of guilt, remembering that I made a commitment a long time ago. Time or faith had fulfilled their side of the agreement in getting me to the opportunities that I needed to do this, but I hadn't fulfilled it. So I wasn't quite sure how to do that. And like Dr. Singh was saying one day, she was just chatting with me about not being able to get consultants to help her out with a particular mission trip that she was trying to organize. And so for me, this was like a eureka moment, right? And I said, well, listen, I'll do whatever I can. Maybe I'm not a trauma surgeon, but certainly I can help you with the infrastructure. I can help you with the funding. I can help you with some mentorship and perhaps even influence my colleagues who do have the skill set to then join you to help these individuals. Interesting enough, while we were doing this, a simple question was brought up is, hey, while you're there, maybe there'll be some spine injuries. Why don't you bring some spine equipment? And my hat goes off to the industry there, because our industry contacts, it was a matter of a simple phone call. And next thing you know, they had what would amount to be hundreds of thousands of dollars of equipment freed up for free for us to take on our first mission. We went there, and it became very clear that, in fact, you can do spine surgery in global outreach, and you can be safe, and you can be effective, and it can be meaningful. And we'll go more into it because it's grown a lot since then, because there's more to it than that. But it just kept rolling from there, and that then made me realize that there's a huge opportunity for this. And subsequently, I traveled to other places and volunteered as a teacher, and we made multiple other missions volunteering as surgeons as well. So
that's incredible, because you guys have a very, very well-oiled machine. And I would like to talk a little bit more about that also. But before we do that, you both mentioned a little bit about the difficulties getting into global health. And even once you get in, there's lots of challenges. Like you were saying, Parham, there's a lot of difficulties trying to get industry sometimes to give you hundreds of thousands of dollars worth of equipment, essentially for free. Walk me through some of that. There's also other things, like the ethics of it. You mentioned that perhaps some of the things you were doing are not part of your skill set, or that there's a savior complex where you come in and then fly right back out. So what are some of the barriers? What are some of the problems? And how have you gone to address that?
We were very hesitant to do spine surgery in a low middle income country setting for many of the reasons that Parham mentioned previously. We're not going to be there for long-term follow-up. What happens if there's a complication when we leave? This isn't sustainable in terms of, we can help this certain subset of people, but what happens to the trauma in the spine when we're not there? It's expensive. Will we be able to make a tangible difference for even that small subset of people we help? Is it safe to do this? So we had a lot of ethical discussions, internal discussions, how do you choose who to operate on? As something as simple as that, a complete spinal cord injury, even if we fix them and they fuse, they're still paraplegic. And they don't have the resources in that setting to get wheelchair, occupational therapy, physiotherapy, access in villages, up rocky roads. How does that going to work? It's not. So where can we get the best neurologic outcome will then be sort of the incomplete spinal cord injuries. So do we have to make that decision that we don't operate on complete spinal cord injuries? We're only operating on incomplete spinal cord injuries. We had a lot of these discussions, but honestly, through lived experience was how we discovered we can do it safely. We were very, very stringent on what we were doing and why we were doing it, and we had daily discussions of that. But I don't have the answers to exactly, like there are so many challenges, some of which you mentioned. And I think that we're still learning, but the one thing that we have is sort of the interest and the passion to try to contribute, but also knowing that we have many limitations, and we're privileged because I am in a high income country and I have access to resources. Just like Parham mentioned, we can pick up a phone, call an industry rep, and have equipment delivered for us for this reason. So we're so lucky to be able to share that, and I feel that it's our duty to do that, and that's where our calling is sort of in how can we share the resources we have, and how can we make sort of a long-term sustainable solution to sort of global spine care inequity. And so that's what we're really focused on, and there's so many facets to that, including education, implants and equipment, training facilities, all that stuff. And so slowly we're trying to break that down. We're learning so much in the process, and we're trying to figure out what the best way forward is. So I actually don't know the answers.
That's totally fair. And one of the differences, however, on your program that seems really, really stand out is number one, the educational facet of it. Supriya, tell me a little bit about how you're engaging the local population to provide maybe more longitudinal care locally, as opposed to just, flying in and out and doing a 1-week mission.
Yeah, absolutely. So the pandemic really helped us refocus medical missions because travel became impossible. Haiti was actually just not even safe to go to anymore. And it's quite sad, but we're unable to go back to that hospital that we've been to for many years. So we had to then refocus and say, how can we still address the global spine inequity? And we decided to focus on education and training. So initially, pre-pandemic, we actually got a group of surgeons together that were willing to go for a certain amount of time throughout the year to have a longitudinal, 1-year training for a spine fellowship, but in their local setting. So whether that be Nepal or Kenya or Ethiopia. But unfortunately, with the pandemic and the restrictions, the travel restrictions, we ended up then saying, you know what, we can bring them to our facilities. We will fund them so that they don't have to worry about that issue, and train them locally. So in Canada, which is restricted because we're teaching them on equipment they may or may not have access to, with navigation systems that they will definitely not have access to. But at the same time, we can teach them some principles and try to bridge that gap, because really a lot of our fellowship training is for certain countries, and we exclude a lot of the time low middle income countries because they can't afford that. Through funding and fundraising, as well as through our association with Singh, we've been able to fund fellows to come in. We've had one graduate from Nepal, one is currently here with us from Kenya, and next year we have a fellow from Ethiopia.
Amazing. That seems to be a very sustainable model. Tell me more about this program, Singh.
Parham and I have been associated with Singh for a few years now, and actually it's through the COA that we were able to make that link, because the Singh fracture nail, they did a sort of a symposium with that, and I have always been a fan of Dr. Louis Zirkle. I have his book, he's my role model in life, and so I chased him down and I said, please, Dr. Zirkle, can we come to your conference? Because every year I would apply, but it's a limited number of people that can go. And so he was like, absolutely. So he invited us to join him at the Singh conference that year after the COA conference. And we went there and we talked to him about our goals for spine care. And we were able to then meet other like-minded surgeons that were involved through Singh. And it's just literally been I don't know how to even explain it, but we talk about the analogy of water and flow, and it just flowed so well.
Yeah, everything you've been doing seems to be very serendipitous and meant to be, for lack of a better term.
It feels like that sometimes. Yeah.
Parham, the other aspect of it, you touched on it, is the cost. So even with all the education, it does take hundreds of thousands of dollars for spine implants. So even with the best education, the countries that you go to may not be able to afford those. You've done a lot of great work with respect to looking at more cost-effective options. Can you tell us a little bit about that?
Often there's a confusion as to where that cost is coming from. So, for instance, why is it that spine implants are fairly expensive? Is it because it costs a lot of money to manufacture these devices? And relatively speaking, it does, but that still represents a very small fraction of the total cost. There are multiple other reasons why medical equipment in developed countries is very expensive. Some of them are simple safety reasons through regulatory, which then result in expenses. But there are certainly methods to introduce safe, reliable, proven implants to developing countries at a cost that they actually can afford and they can sustain. It just has to be done in a very mindful and cautious manner. I imagine a lot of the viewers actually may not know who Dr. Zirkle is, but he's an individual that's proven that over the last more than 2 decades it's been now. So Dr. Lou Zirkle himself was an American surgeon who had experience in Vietnam, came to realize that there's a lot of individuals, young, healthy individuals, who have prolonged hospitalization and chronic disability because the physicians in those countries don't have access to devices to fix long bone fractures. So in particular, intramedullary nails for tibial shaft, femoral shaft fractures are a common procedure in North America and essentially standard of care that these folks didn't have access to. So he almost independently initially started a manufacturing facility within the US, making, which at that time were FDA approved implants, and making them at a cost with a design that not only could it be utilized in an easier way without access to fluoroscopy, but also to be made, shipped, and manufactured for limited cost, and in fact donated free. And so he's been successful in setting up a manufacturing facility that has been designing and making now even other implants and providing these to developing countries at either a very minor cost or for free altogether. So he's shown us that this is possible. Over the last several years, there's been a big ask from the surgeons working in the countries that spine fracture care has a relationship with in improving spine care for their patients. So even though we were trying to pursue this because we felt like it was the right thing to do, the ask actually came from their surgeons. And we've been trying to find pathways to do that, and there are several pathways and that we're currently exploring. On one end, there are multiple manufacturers of devices that make implants certainly comparable to what we have access to and what we use on a daily basis, and are able to sell them at substantially lower costs due to their manufacturing methods and labor costs and all those things. But some of them haven't been tested through the same vigorous processes that, for instance, FDA requires. And so as part of our project, we are collecting these implants and testing them independently to see if they would in fact pass the usual standards that are required by the FDA to know whether they're safe or not. Beyond that, we actually have a small design team trying to figure out whether we can make our own spine implant with the intentions of not making something new or fancy, but intentions of making something that is affordable, reliable, and also easier on inventory. There's a lot of modularities that can be taken advantage of to reduce inventory, reduce complexity of maintaining your implants in-house, and also certainly cost. We have that on the go as well. So at some point, I think as an organization, we're going to have to decide whether it makes sense to manufacture a device that's particularly of the mindset of having something reliable but affordable, or simply acting as an independent body who can advise our colleagues in other countries as to what implants should perform the same as the implants that we've been using for 2-3 decades and we know have been proven.
You have taken global orthopedics from what seems to be very baby steps, this process now that is sustainably and viably giving education to local areas, which really is kind of the crux of it, right? Because you want to be able to educate people so that they can manage all those complex things locally. If people are interested in learning more about any of your projects and your initiatives, or if there's any listeners who want to become one of your fellows who are from one of those developing countries, how do they get a hold of you? How do they find out more?
Through Sign. We do have Sign Spine, so there's a website where they can certainly get more information on the program. We're still very early in development phases, so one of our restrictions is, we don't want to do too much too fast. We want to really start with a few number of fellows and go back and follow up at their institutes and make sure, even through research, and make sure that they're having good outcomes, they're doing safe spine surgery. So we don't really want to start at like 1 million sites at once. So we have a very targeted sort of 5-year program and with a very discrete plan. So right now, we're not delivering to the people that need it, but we need to start slow and make sure that it's going to be reproducible, that it's going to be safe and have good outcomes. After, the few fellows have come through their training, we're now going to go back to their centers, make sure that they have the implants available, make sure their ORs are set up, they have access to everything, and follow the outcomes in, the first year of patients that they've operated on, followed their x-rays, patient outcomes, and see that we can just sort of publish that to say, they're doing safe spine surgery, they have access to implants. This has changed their outcomes, in this population. So this is safe, and now we can then take that and also use that in North America to say, come support us, and then we can help more people.
Supriya and Parham, what do you think then, after all these advancements, is the next step for global health and global orthopedics?
The ultimate goal is the same goal that I would have as a teacher to our residents, or even as a parent to my children, and that is to become useless to them. Once you've achieved that as a teacher, once your resident no longer needs you, or your fellow no longer needs you to perform a procedure that you've been training him to do, you've been successful as a teacher. And so once any of these countries that we're trying to bring spine surgery to no longer need us in any shape or form, then I believe we've been successful in trying to achieve what we're trying to achieve, which is to equalize care. In my mind, in an ideal world, it doesn't matter if you break your spine in Kenya or South Sudan or China or US or Canada. You should receive the same care, and it should be evidence-based care that's proven to work, and it should be done by an individual who has sufficient training and the right number of hours to do that procedure efficiently with equipment that is reliable, dependable, and affordable. That should be true for all of those countries. That's kind of where I see this going. And the truth is, most of the time, I don't know exactly what's good for myself. So I'm certainly not going to, sit here and I know what's going to be good for the citizens of Kenya or the surgeons of Kenya. And so all we can do is develop these collaborations with them and give them what we have. And so what do we have? It's some knowledge. They have access to the same knowledge that we do now, to be honest. So just pure data. Teach them the surgical skills that we have. There are certain areas where our surgical skills are slightly better. Why are they better? Because we've had the privilege of being able to practice those skills, because we have the resources to do so, and then help them get access to reliable implants. So if we can do those three things to a point where we're completely eliminated and it becomes sustainable and we're completely forgotten, I would consider that the success of this project.
I love that. I mean, that shows how passionate you are about this. It's treating it like your kids. It's amazing. Supriya?
It's really hard to follow that answer, but certainly in my experience, what I've found is, it's so meaningful to get to be a surgeon and to do the work to impact one patient. An example, when we went to Haiti, we saw a patient with TB, like tuberculosis. His spine was collapsed. He's a pediatric patient. He was having neurologic deficits in the ICU. We were able to intervene, correct his alignment, free up the spinal nerves. He was walking a few years later. We could see him growing and thriving, and we felt, this is why we do what we do. This is the passion of what we're doing, and that we've made a huge difference to that one individual and his family and maybe associated people around him. But that's a very small difference that we make. I think really where the impact and where the future is that education piece where, the fellows that we're training, that they go back to their centers and they're going to be training and operating on so many people, and that's how we get that sort of exponential effect of what we do. So I think it really comes down to the impact of training and education, and that's how we really make a difference. But I really do echo the previous sentiments in it, just to add to that.
Both of your passions for this project really, really shine through, and you guys are making these incredible strides and a huge difference. So thank you for all your work, and thanks for being here and sharing all that. So again, that's Dr. Supriya Singh and Dr. Parham Rasoulinejad.